pass the first test. So I'm Joe Tay. I work in Edinburgh in the southwest area, and I am going to basically be talking very local to Edinburgh, very local to the southwest of Edinburgh. I will be making references to a health needs assessment that was done in 2017, and the action points of which we have been doing in 2018, and a lot of numbers come from there. And I wonder if I could have a hands up of any GPs or anyone who works in primary care here. Oh, thank God. So there is a handful, and I'm glad. Because really what I'm hoping will come out of this is some maybe practical advice, and I'm more than happy to take any questions if anyone wants to know how we did what we did. It might be that none of this is particularly exciting, but it's exciting to me. No, never done. Okay. So this is a map of Edinburgh, and southwest, that's where I am. And in this 1 year, we didn't do too badly. But if you look at the colours, and blue, dark blue shows the average over 4 years, you can see that we did quite badly. The big black arrow there. And in fact, this is what made me interested in what was happening. So between 2014 and 2016, from having been a practice that supports harm reduction for many years and having not really that many drug deaths, suddenly from having either none or one a year, we went to having about 6 or 7 a year. And that was really quite shocking and tragic. So we started looking into things a little bit. Why was this happening? And one of the things we identified really was, despite having a naloxone program, and a national naloxone program, the vast majority of our patients hadn't accessed this. Basically, only 2 people had naloxone training. The other thing as well, some data from the HNA, the Health Needs Assessment, identified the group of people who were most at risk: single white males, long-term history of polysubstance use, and also with comorbidities, mental health, and also physical comorbidities. And I'd just like to point out as well, mental health, number 1, respiratory conditions, number 2, Hep C, number 3, and you'll see why in a minute. So this is us, Site Hill Breed Practice. We have 228 patients for whom we provide harm reduction services to, primarily through methadone prescribing, a smaller amount of buprenorphine prescribing. Our practice size is 8,600, so proportionately we have quite a few patients whom we manage. And as mentioned before, 2014 to 2016, really an unprecedented spike. This is, it's not very clear, but it is the output from the health needs assessment that was done by Public Health in Edinburgh. And I just want to highlight a few things. Provide harm reduction as part of all service contacts, that's number 2. Number 4, improve support for general health and well-being. And number 5, strengthen services for vulnerable groups. So 4 and 5 in particular, I feel, are very basic general practice things. And if you look on the other side, that's the views of the people who have injected drugs. And something that is quite prominent there really is stigmatization. And that's something I think that someone really shouldn't have to face when they come and see us in general practice. So, from the health needs assessment and from identifying our own crisis, I suppose, these were the things I thought were priorities for us. Naloxone training, providing that to our population because they weren't getting it. Reducing high-risk prescribing, so what were we doing that was potentially risky? Addressing chronic pain, so I'm really glad that was brought up earlier, because actually chronic pain is an issue regardless of whether someone has substance issues or not, And as a GP, we scratch our heads about what we can do about this. Maximizing the people out there who are also trying to help, I think, because sometimes being a GP can feel quite isolated. Building therapeutic relationships with our patients and addressing chronic conditions. So, what did we do? So, the gap in naloxone provision in Edinburgh was already identified by the health needs assessment. 80% of opiate substitute therapy, methadone, buprenorphine, is provided through GPs, and yet we weren't really providing patients with too much naloxone. So this chart, the red shows the practices prescribing naloxone, the blue is how many kits were provided. So basically a very small number of practices were providing most of the naloxone within primary care. So our first thing was a naloxone clinic. We presented this at the Society for Substance, I can't remember what SSA stands for, sorry, we presented this somewhere. And with a naloxone clinic, over just about 9 or 10 months, we went from 2% of the population having received naloxone kits up to 27%. So that was in a very short period of time. So that was 2016, and I got our IT person to check, and we're now at 50%. It's not 100%, but you know, that's not bad. I probably wasn't very patient-centered when I started this, because basically we told our patients they had to do naloxone training. It wasn't an option. And I felt it was justified at the time, primarily because of the high number of deaths. So in my view, this was a crisis and we needed the kits out there. And if anyone ever wants to ask me about how we actually did this in practical terms, I'm more than happy to speak about that. Naloxone is everywhere in our practice. We've got loads of posters, loads of cards. When we did this really for several months before we actually started the naloxone clinic. And so when patients came in and we said to them, you know, have you heard of naloxone? They say, oh yeah, I'm not sure why, but yeah, I've heard of naloxone, and that's why. So it's just really trying to, you know, get it into people's consciousness. Now, interestingly, they knew about naloxone because of our campaign, but they weren't aware of the national campaign at the time anyway. This is me doing naloxone training. So really, I suppose, the reason I thought this was really good is because one of the interesting barriers I found to doing the training in practice was stigma, self-stigma. When you brought it up with patients, they felt that you were saying to them, I know you hang out with lots of people who use drugs, and that's why I'm doing this with you. And so a lot of people didn't want to do it for that reason. And it was really trying to change the narrative to make people realize that, in fact, what I'm asking you to do is to be someone in your community who is able to save a life. And the outcome from that, even if there was resistance at the beginning, was people went away with their certificate feeling quite chuffed with themselves, actually. So the kind of steps to get the clinic launched included attending a training for trainers, so Edinburgh offers that. As I said, we made it compulsory in our practice. I don't know if I'd recommend that, but I felt we had to at the time. There was dedicated time to do this. My partners in the practice, worked harder so I could do this, basically. It was handed out, the kit was handed out at the time. It was on their repeat prescription, so they could get refills, really, without ever seeing us if they wanted to. At the time of training, their appointments were tied into their prescriptions, so there weren't any DNAs. Again, controversial, but I felt I had to do that, and they got a certificate at the end when they did the training. And yes, it can be done in 10 minutes. Chronic conditions. So, as you can see, as mentioned earlier, mental health, in our practice, this is just our practice, large number had comorbidity of mental health as well as substance use. COPD, respiratory, that was the second one, and Hep C is the third one. So in this group of people who were on our substitute prescribing, who needed to have naloxone training, we also had a number of other health problems as well. And I felt it was really quite important that we tried to do something to take care of their overall health, not just this one thing. So we applied for a bit of funding from the Health Needs Assessment folk, public health, and we've got funding for 12 clinics. Those clinics are just only about, well, pretty much anything the patient wants to talk about, but definitely not about their prescription or their prescribing. That's done elsewhere. 20-minute appointments, which, if you know anything about primary care, is luxury. And a lot of the people who came in had chronic conditions. We were targeting them specifically, things like cervical smear screening. And the other thing as well is we weren't afraid to talk about chronic pain, because quite often these are the heart sync consultations. So this is going really quite well. Interestingly, I get told beforehand what the patient wants to talk about, and sometimes you look at it and go, oh, this is really going to be difficult because it's all about chronic pain. And they come in and speak to you for 15 minutes about how they feel really bad, that people can tell that they're a drug user because of their teeth or because of how they look. And I think it's just having someone treating them like a human being for 15 minutes seems to be helpful. Tackling chronic pain. So I've gone on about this a bit. I think certainly in Sighthill we're really keen on treating this as an issue not just for people who use substances, but really for everyone. And I think the key issue here really is something that we're not very good at in general practice, and that's realizing that we can't sort everything with a tablet or a pill. And that the reasons behind chronic pain are not necessarily anything much to do with the physical state of the person. It has a broader context that we tend to ignore. So we give up prescriptions, we put them on repeats, we hope the patient doesn't come back, and that's that. And we do that for not just opiates, but really a lot of different types of medications. And we do treat people who use substances different from people who don't. So, you know, if someone is a substance user and they have severe pain, we basically hum and haw before we do anything adequate. Now, I have to make the distinction between acute and chronic pain. So here really we're talking about pain that's been going on for at least 3 months, if not longer, and quite often with no specific diagnosis. So what we've done basically is, rather than dreading the consultation, we are bringing it up in a wide conversation. We are getting people in who can help that doesn't involve medications. We're getting the naloxone people in. This is slightly controversial, I suppose, in a way, but the person who basically provides us with our kits is coming as well, and he'll be setting up a wee stall and actually hopefully showing people how to use naloxone. This isn't just people who use substances, this is for all patients, although we have been trying to get people who use substances to come. And the idea here is to make everyone realize actually that naloxone can help all of us, and we really have a responsibility, all of us, to be able to use it. Safe for prescribing, so you may or may not know that the gabapentinoids have been causing a lot of problems, and personally I feel that the spike in deaths that we had in Sighthill was really quite closely associated to the high number of people who were on gabapentinoids. So again, bit controversial, but basically we just decided we weren't going to keep people on these because they were just too dangerous. So we used resources that we had, for example, an integrated pharmacist. We worked out what was the best reducing prescription for patients, but we had this advertisements out there for several months beforehand, and actually when patients came in and we told them, they weren't really all that taken aback, they weren't all that upset, and they realized partly because they had friends who had died as a result of combining gabapentinoids and opiates. Some suggestions, ideas for general practice. Naloxone clinics. In my setting, I felt I had to provide the training because there was a personal connection, but also because there would be high DNA rates or non-attendance rates otherwise. We got a little bit of funding to make small changes, so that's like the chronic conditions clinic. The idea behind that really is to allow people to feel like human beings rather than a drug user, and also to build on what general practice is good for, which is trust. Patients trust us most of the time. We've had input from integrated pharmacists. We've done QI projects in chronic pain and gabapentinoid prescribing. There's a Transformation Stability Fund, which general practitioners might know about, and from this we have a CPN who does the prescribing for us now. So when a patient comes to see us, the prescribing side is done. What I mean by that is substitute therapy. So we can actually just focus in on what the patient wants that day, their health needs, as opposed to chat about prescriptions. Something else I'm really quite excited about is the Scottish Government has a fund to encourage general practitioners to provide what's called extended hours, so appointments before 8 a.m. and appointments after 6 p.m., I think, or after 5:30 in the evening. And the idea is to improve access for patients. So we got permission recently to use that extended hours time to provide something called group consultations. So that's not very common in Scotland yet. It's quite common down south and other parts of the world. Examples include things like HRT clinics or weight management clinics. It's run by a facilitator and a general practitioner. People who do SMART meetings or AA or NA will be familiar with the concept of a group setting. And the idea really is a patient-set agenda with your general practitioner there, and someone else facilitating and working on a common problem. So, for example, chronic pain. We're opening this to everyone. With my special interest in addictions, I'm going to make a point of making sure that at least some of our patients are people who are on our NES list. And I'm quite hopeful, actually, that sort of a bit of GP interest in peer support might actually improve things a little bit. But it's an interesting approach because we're not having to get any extra money for this. We're just using resources we already have in a slightly different way. I think that's me. Oh, good.